Good afternoon, everyone. I am presenting again. This was originally to be presented by Dr. Anu Malik, and I am representing her here. So this is the overview and basic workup of a case of microbial keratitis. So microbial keratitis is proliferation of microbes associated inflammation and tissue destruction within the corneal layers. And the corneal ulcer is breach in the corneal epithelium with stromal infiltration. And abscess is when the epithelium is intact and there is corneal infiltration. So they are natural barriers to microbial keratitis, which are anatomical, like orbital rim, eyelids, cilia, intact epithelium of the cornea and conjunctiva, and mechanical barrier like tear film, blinking reflex, lacrimal drainage system, tear film, consisting of mucus layer, IgA complement, and lactoferrin, etc. So there are certain risk factors associated with corneal ulcer in which all these protective mechanisms are broken, which are like trauma, contact lenses, topical medications, ocular surface disease, bullous keratopathy, previous surgery, lid and adnexal pathologies, sac diseases, lid abnormalities like entropion, ectropion, misdirected cilia, etc. like ophthalmos, and systemic disease like diabetes, SJS, Sjogren's, AIDS, advanced malignancies, alcoholics, measles, etc. And occupational also like farmers, animal handlers, and gardeners. So epidemiology is in most of the studies, the majority consists of bacteria, which are mostly gram-positive, Staph aureus, Coagulase negative Staphylococcus, Streptococcus species, and gram-negative like Pseudomonas. Then 30% is Fusarium, which mostly is Fusarium aspergillus, Aspergillus flavus, Niger, and Candida. And viral is herpes simplex zoster and varicella zoster. And protozoa can be Acanthamoeba, Microsporidia, and others like Nocardia and atypical Mycobacteria. So there are stages of ulceration. One is the progressive stage in which there is social shaped, this necrosis and ulceration occurs with deeper penetration. Then there is regressive state in which there is healing, line of demarcation, margin and floor becomes smooth and transparent. And then there is stage 3, which is the healing stage where epithelialization starts. So symptoms we very well know: pain, redness, discharge, blepharospasm, defective vision, and signs also: discharge, corneal transparency, and epithelial defects, satellite lesions, etc. So we should document the patient's finding, which is very easy to do and help us in monitoring the patient. Those superficial vascularization is drawn in these red diverted lines, and corneal edema in blue, and infiltrate and ulcer is shown in green. Then grading is again mild ulcers less than 2 mm, depth less than 20%, no scleral involvement, moderate ulcer 2 to 5 mm, 20 to 50% depth, and severe ulcer more than 5 mm, more than 50% depth, and scleral involvement is present only in severe ulcers. So in bacterial keratitis, usually symptoms are severe. They are severe pain, rapid progression, mucopurulent discharge, mobile hypopion, and normal corneal sensations. In fungal keratitis, usually it's an indolent slow course with elevated edges, dry looking surface, feathery margins, satellite lesions, fixed hypopion, and it can be pigmented, and normal corneal sensations. So viral keratitis, corneal sensations are diminished, and it could have a fine lacy pattern, linear defect with Baird's trauma. And Acanthamoeba, the distinguishing feature is severe pain, and there will be history of fall of some dirty water or contact lenses, and there will be photophobia and waxing and veining course will be there. And there are ring infiltrate, pseudodendrite, radial keratoneuritis, satellite lesion, ring shaped infiltrate, and severe limbitis. So Acanthamoeba, apart from these, can mimic any of the 3 keratitis, whether it's fungal, viral, or bacterial. It can look like any of those. So in cases of investigations, we have to do corneal scraping. Ideally, we should do corneal scraping in each and every case. Besides the very small, less than 2 mm ulcers, we need not do the corneal scraping. Then conjunctival swab ideally should be taken, contact lens cases and solutions, and corneal biopsy, suture biopsy, and AC tap also may be needed in certain conditions. So the most important stains are gram stains and KOH. Other stains are specifically used in certain conditions, which are Giemsa, calcul floor white, or Zn staining. So culture and sensitivity should be done, and most important are blood agar and chocolate agar. and non-nutrient agar for acanthamoeba, and then SDA media and brain heart infusion. So investigations, if the patient is not responding with your staining and culture reports are also repeatedly negative, then corneal biopsy can be done and suture biopsy can be done. So corneal scraping is, if the ulcer is more than 2 mm in central, then always it has to be done. Then for corneal scraping, the already first speaker has explained the procedure. So for gram staining, we see these bunch-like, grape-like arrangement, and in gram positive organism in chain, we see, so these are the different. So in KOH preparation, it is very simple, and we should all do KOH testing. We should just put the specimen, no need to even spread it. Just put 1 drop of 10% KOH and place the cover slip and examine under the microscope. KOH just loosens the stromal laminae and you are able to see it under the microscope. If you don't have KOH, you can even stain with trypan blue staining, which we use in cataract surgery. So this is the picture how the yeast and the aspergillus looks like on KOH staining. And these are other stains, which respective picture like gram stain, Gimsa. And gram stain is best for bacteria and for visualized fungi and acanthamoeba. Even microsporidia can also be seen in this. In Gimsa staining, bacteria, fungi and chlamydia is the advantage in Gimsa staining, and Zn staining is usually for mycobacterium and nocardia. You can make out mycobacterium with negative staining in gram staining. You will suspect it because there will be unstained areas, then you can do Zn staining. Acridine orange is done for bacteria, fungi and acanthamoeba, and chalcofluor white is very useful for fungi and acanthamoeba but needs special equipment. And then sensitivity and specificity, gram staining is very, its sensitivity is 32 to 98% and specificity is 99%. And KOH stain is sensitivity is 72 to 91 and specificity 99%. And if we are not able to diagnose with these, then we can take a corneal biopsy, especially if the ulcer is very deep. And if still the ulcer is very deep, corneal abscess, epithelium is intact, then we can just pass on a suture, a silk suture, and with a very small fragment, and then when we can cut that fragment into 2 pieces and send the 2 fragments for fungal and bacterial culture sensitivity. So direct plating on culture media is preferable, and it is easy to do also. For we should know the timing. Aerobic culture takes 7 days, and anaerobic to 7 to 14 days. And mycobacterial and fungal cultures take 4 to 6 weeks before reporting the no growth. So ASOCT can also be used for mainly monitoring the patient. So monitoring keratitis, especially deep stromal involvement and endothelial plaques, we can do ASOCT. And parameters measures are corneal thickness and infiltrate area, and infiltrate thickness and infiltrate width. And these can be monitored on progressive follow-ups of the patient. Confocal microscopy is useful only if the lesion is very deep. If you can scrape the patient, then confocal microscopy is of no use. But if you cannot scrape the patient is not responding to anything, then confocal microscopy can show you in vivo the organism, especially acanthamoeba cyst. So all these help us in establishing the correct diagnosis, identifying the causative organism, identifying the underlying risk factors, ocular as well as systemic, and assessing the response, and then managing for the recalcitrant cases. So risk factors should also be managed. If the patient is having blepharitis or dacrocystitis, trichiasis or leg ophthalmos, then you should manage the cause also. And if he is having ocular surface disorder, or if he is using contact lenses, then he should be taught about correct usage of contact lenses also. And then systemic conditions like diabetes and immunocompromised state should be managed. So scraping, the general management scheme is that after scraping, if fungal hyphae are seen, then you start with antifungal therapy with 5% netamycin. If you see on gram staining or culture sensitivity, gram ulcer which is less than, if you see organism on gram staining, then clinically, and the patient is clinically responding, then you can continue with the same treatment. If clinically it's not responding, then you have to change the treatment according to culture sensitivity. But if the patient is responding and your culture sensitivity shows some other organism, then you never change the treatment. You go for the clinical response only. So if the patient is not having any, then if the ulcer is less than 2 mm and superficial and it's not involving visual axis, then you can continue with your monotherapy with fluoroquinolone. If the ulcer is larger, more than 2 mm, and it involves the visual axis with deep stromal abscess, then you can give the combination therapy with fortified antibiotic drops with cefazolin and tobramycin. So if you have to document your findings so you can manage the progress of the patient. If you see good response, then continue the same treatment. If you see no response, then adjust the medicine according to the culture sensitivity. If again there is no response or progression, then discontinue the medicine for 24 hours and then repeat the scraping or corneal biopsy or culture. If it is a severe keratitis with scleral involvement, impending perforation, then you have to give systemic therapy also. Otherwise, systemic therapy or oral antibiotics are not recommended. If it is a perforated ulcer, less than 3 mm perforation is there, then you can go on with BCL and glue. Even Tinan's patch graft can also be done there. If it is more than 3 mm perforation, if it is central, then you have to do TPK. If it is peripheral, then you can do patch graft. So management for the first 1 week, the ulcer is in sterilization phase. Then after the sterilization phase, you have to analyze the patient after 1 week, which comes to healing phase or 1 week. So the frequency of antibiotic administration is, first you have to give the loading dose every 5 minutes for first half an hour, then 1 hourly round the clock for 48 hours, and then 2 hourly until you see the healing of the epithelial defect. So usually the duration treatment, bacteria should respond within 3 to 5 days after healing. And the empiric management is, if it is bigger ulcer, then concentrated cefazolin and concentrated tobramycin. Then supportive therapy is pain management, cycloplegia, anti-inflammatory, lubricant, and anti-glaucoma. So after assessing the response, we can, if the patient, we can assess by reduction in sign and symptoms, and we can give these broad spectrum antibiotics. So monotherapy versus fortified antibiotic therapy is, if you are not able to form fortified, if the ulcer is very small, then you can give monotherapy. There are advantages: cheaper, readily available, stable, less toxic. But if the ulcer is larger, then you have to give fortified. So if already this has been covered. So if it is a non-healing microbiological keratitis, then organism, if it is traced, then correct antibiotic or specific antibiotic has to be started. And you have to see if it is an inadequate therapy, patient is not putting 1 hourly. You have to check the compliance, then increase the dosing to 1 hourly. If the patient is non-compliant, then you have to admit the patient, and you can also give subconjunctival injections. And then if the patient is immune compressed or drug toxicity issues are there, then systemic antibiotics can be given. If there are incorrect antibiotics, then you have to treat according to the culture sensitivity report and review after 1 week. If organism is not traced, you can repeat the scraping corneal, then even if no organism comes, and corneal biopsy, atypical microorganism or drug toxicity should be checked for, and then surgical intervention should be done. Thank you everyone for your patient listening.
So any questions on these topics?
KOH should be fresh?
No need, you can store it.
It's 10%
You can
or
prepare
20%?
and store it in a bottle.
It's 10% or 20%?
10%.
And you said probably if you don't have, you can use strip and glue also.
We can use tripanolis. So the KOH, what KOH is doing is it's just digesting the corneal lamellae. So trypan blue stains the fungal filaments. They, in LVPI, they are routinely using it in their peripheral divisions.
Because sometimes you know, strip and glue is available
Yeah,
in a setup.
KOH you
But
cannot
KOH
store.
is
KOH you
not
cannot
that
store
you can use
indefinitely. KOH you have to make after 1 month or so. So with trypan blue, storage problem is not there. So
And
KH,
it's readily available. You know,
it's readily available, and the process is same. You just have to put 1 drop of trypan blue and let it stay for some time and cover slip, and then you can see.
Sometimes
And
it's
it's
how long? For
it's
20 minutes?
30 seconds or so,
30
not
seconds.
much more, and it's even easier than KOH.
Acha.
The visualization is even easier than KOH.
Thank you. And what about intrastromal like antivenom like voriconazole and for?
Yes, sir. The thing is that if your patient is not responding, you can give intrastromal injections with TT syringe. You can give at multiple sites, 5 or 6, wherever the lesion is there. You have to inject in clear cornea around that lesion, and you have to see for the response, the same response as when we seal the wound of phaco. That stromal hydration is there, na? The same sort of appearance will be there. You have to inject it deep, but you have to keep in mind that the half-life of voriconazole is very less. It will go away in 20 minutes, around 20 minutes. So you have to give it repeatedly. One injection may not be suffice. You cannot say ki after one injection it's not effective. You have to repeat. You may have to repeat it 2 to 3 times also.
Any drops available commercial for acanthamoeba?
Acanthamoeba, no sir. No, voriconazole is also, you have to procure the PHMB. You can buy it from US actually. We have bought it from US.
Some
It is
people
a,
are using probably dental, like like a mouthwash or something.
no sir, chlorhexidine is there. Chlorhexidine eye drops you can, but PHM, that is more epitheliotoxic. And in acanthamoeba, the treatment extends for even a year. It is very difficult because you can treat the organism on the surface, but there will be cyst which will be deep inside. They will again resurface. So you have to continue the treatment for a very long time. So you cannot give a very epitheliotoxic drug. So the choice of drug is PHMB, which is lesser epitheliotoxic.
I remember there's something called golden eye drop. Someone from UK, somebody I saw with somebody.
PHMB is provided by Orolab people, so
Yes, sir. And Shroff Eye Center also provides it. But you have to send the patient with the 2 lubricant drops. Shroff Eye Center in Delhi, because I am from Meerut, nearby Delhi, so I can tell you about that. So they provide PHMB, prepared PHMB. You have to send the patient or their relative. Patient need not to go. Patient has to go with 2 lubricant eye drop and your referral that you need PHMB, and you are suspecting a acanthamoeba keratitis. So they will provide the PHMB eye drops. They will be valid for 1 week only. Then again you will have to. And first of all, the main problem is that you have to establish the diagnosis of acanthamoeba first.
Ma'am, till how many days we can give eye ointment acyclovir? We say we have to give for 14 days.
for iridocyclitis.
For normal keratitis.
So for 10 weeks we had to give.
For 10 weeks.
Yeah, until you give the topical steroids. So you have to give acyclovir also, oral acyclovir.
Ma'am, eye ointment. Acyclovir eye ointment.
You can continue until the topical steroids, because when you are putting topical steroids, the epithelial keratitis can occur again. So that's why we give.
Thank you.
What about a patient with significant cataract and then, old herpetic, this ulcer, healed ulcers? How do you go?
So at least there should not be any recurrence, at least for 1 year.
No active.
No active, no active. So you have to keep the patient on prophylaxis at least for 1 year. It's 400 mg.
See, in a rural area, you have a very significant cataract, and then this person had old, this herpetic keratitis, and he needs surgeries for rehabilitation.
So we have to explain the patient that there can be resurgence of viral keratitis, and in the post-operative period you can keep the patient on prophylaxis again.
And that prophylaxis for 1 year.
Yeah. So because the recurrences are more common within the first 1 year, so they have advised to give prophylaxis in the first 1 year. So after 1 year, the recurrence chances comes down. So the head study has...
Patient comes to me with an whitish opacity, there's old KPs, no AC reaction, significant cataract. I can go ahead with the cataract surgery
Yes, you can go.
And that prophylaxis will continue for about 1 year.
Yes. It is better to continue the prophylaxis.
And
Then the chance of recurrence will come down.
so acyclovir 400 milligram in BD doses
Yes.
for 1 year.
Yes.
And after every 3 months I have to take for liver function test and the
It is better to do if the renal profile and liver profile. So every 3 months. You have to follow the patient every 3 months. Because we have to see the complaints also. Sometimes the patient will stop on their own acyclovir. So it is better to see the patient every 3 months even though he doesn't have any recurrence.